This is a case which we did some time ago. This is a 35-year-old gentleman, resuscitated cardiac arrest, an anterior wall MI, thrombolized outside, had COVID at that time, from which he recovered, normal LV systolic function, he had gout and recurrent renal calculi. And this was his culprit lesion. You can see in the LAD, there is a critical lesion which is 90% in the proximal LAD, and you can see it in two views. And this is a non-culprit lesion in the right, which has multiple lesions, which you can see in the mid-segment, in the distal segment, in a tight PDA, second PDA lesion, which you can see there. So what we're now going to discuss is not the first lesion, which I'll quickly go through as what do we do, but we learned a lot on that lesion too. So this is a pullback of the IVUS. You can see the distal, there was a muscle bridge, and you can see lesion in the proximal LAD, and you can see that the lesion is extending from the mid-segment to the proximal segment. You can see that the diameter distally is about, you can see here, that's the distal, that's the proximal, and we decided that we had disease up to the ostium. This was approximately a 2.5 to 2.75 distal and a 3 to 3.5 proximal. So we're going to use a 275 into 38 millimeter stent to deploy across the stenosis. And you can see the length is about 36.3 millimeters. So this was the first step. So there's a muscle bridge distally. There's a lesion in the LAD. It's about 2.5 to 3, and the length is around 37 millimeters. So we got in a stent to 2.7538 and deployed it across the lesion. And you can see that the problem was that we missed the ostium. There was a large block burden in the ostium. The lumen area was 7.3, and the post-dilatation, we only went up to a 3 millimeter balloon, size to the lumen to avoid a proximal edge dissection. So this is the post picture, and you can see the bridge, and then it comes through. The distal stent looks reasonably well deployed. The areas distally is about 5.3 and proximally is about 7.5. There's a little miss of the ostium of the LAD, so we didn't go very up. We thought that this was fine. We got good lumens. We didn't want to create a problem in the ostium of the LAD. And then we did an IFR. This is just to show the culprit lesion. We'll discuss the non-culprit lesion. So you can see the IFR, it's 0.91. It's a gradual step, and you can see that very clearly. You can see it's a gradual step going on. And with the IFR co-registration, you can see the delta points at which it is maximum. And you can see clearly here that the delta points, you have a 0.91, and the delta points are mostly here. And this is where the bridge is. So you can't fix this. And most of the points here are a small gradient. So this is something what we have to understand, what you can fix and what you should not. And this IFR pullback really tells you where is the problem and what we should do, so that what you can achieve by overdilation and when you should overdilate the stent, because problem here is more in the bridge rather than in the proximal stent. So that was done, and no further dilatation. So the case part which we're going to discuss now is this right. So here's the right, multiple lesions in the right, and you can see a tight lesion which is in the distal PLV to the right ventricle branch, and very, very proximal lesion. So we decided to check the IFR, and this is the IFR. So the IFR over the vessel is 0.82, and so it's significant. And again, we do a co-registration and pull back. And what you can see that all the points and all the deltas are around that distal critical lesion. There's very minimal delta across. So the IFR tells you that possibly we may need to only spot stent this area and not go beyond that. Well, so this is the case, and this is what we're going to discuss after Ajay presents his presentation. I'd like to know during the discussion as to what people would do on this case.